Thank you very much for the opportunity to participate in the series of talks organized by the ICON Network on Cardiomyopathies. I will present a paper called Preventive Sudden Cardiac Death and Neurologic Recovery in Inherited Heart Diseases. Sudden death can be the first manifestation of a heart disease, such as cardiomyopathy or canalopathy. Inherited cardiac diseases account for 10% from the total and affect particularly the younger ones at the earliest. Different strategies to prevent sudden death have developed over the last decades, from early diagnosis, risk stratification, and therapy of our patients to implementation of protocol for assistance of out-of-hospital cardiac arrest. The overall survival rate for cardiac arrest is about 10%. Early and acute resuscitation is associated with neurologic recovery. The objective of the study was to quantify prevented sudden death and the neurological recovery of patients with inherited cardiovascular diseases. 257 consecutive cases of sudden death, with a mean age of 42 years old, almost 80% men, with suspected or definitely diagnosed with an inherited cardiac disease, evaluated in our inherited cardiac disease unit in Murcia during a period of 9 years, were included in the study. Ischemic cardiac cause and other non-inherited and non-cardiac causes were ruled out. Cases were referred from Institute of Legal Medicine of Murcia or from any of the 9 hospitals of the region. Epidemiological, clinical, and autopsy aspects were analyzed. Prevented sudden death was defined as a combination of resuscitated cardiac arrest and appropriate ICD therapy cases. The study had 3 aims. The first one, to assess causes of sudden death in inherited cardiac disease. For those, we include 204 cases referred from the Institute of Legal Medicine and 53 resuscitated individuals referred to our unit. For the second aim, the study of preventive sudden death, we include also those with ICD therapies. And for the third aim, assessment of neurological recovery, we include only those 53 individuals resuscitated cardiac arrest. This figure illustrates the final diagnosis of the cases included in the study. There were some cases, 47, included as likely inherited based on their young age, family history of inherited cardiac disease, and absence of ischemic heart disease, despite no autopsy report was available. In those in whom we reached a final diagnosis of cardiomyopathy or canalopathy, the distribution of the condition was the majority, 50%, had hypertrophic cardiomyopathy, followed by nearly 18% of arrhythmogenic cardiomyopathy and 7% of dilated cardiomyopathy. 5% had long QT syndrome, 5% idiopathic ventricular fibrillation, 2% Brugada syndrome, and 1.5% CPVT. Other 8% include unclassifiable and or mixed phenotype. This table summarizes the main characteristic of the population regarding diagnosis. Males predominated in all but CPVT and long QT. We found younger patients with arrhythmogenic cardiomyopathy, idiopathic ventricular fibrillation, and long QT syndrome. This is the the age distribution of cases included in the study. Most cases were in the middle age. This figure shows typical histological findings. First, on the left, a normal macro and microscopy of a morphologically normal heart from a 14-year-old girl with CPVT who dropped dead during an argument with schoolmates. The second is a 40-year-old male who died at work with hypertrophic cardiomyopathy with fibrosis and disarray. The third case is a dilated cardiomyopathy with a rounding appearance of the apex, patchy interstitial fibrosis surrounding muscle fiber. This was a 45-year-old male who died at home. And the fourth is a heart with large fatty infiltration at the right and fibrofatty at the left ventricular wall. This was from a 39-year-old male who died in his sleep. In regard of the context in which sudden death occurred, most sudden death or resuscitated cardiac arrest were at rest. 24 cases, 9%, were triggered by intense physical activity, and only 2 cases, less than 1%, by intense emotional situation. 53 cases, 20% of all cardiac arrests were resuscitated. A statistical significant association was observed between sudden death and the male versus female sex, and between resuscitated cardiac arrest and canalopathy versus cardiomyopathy. The age of the deceased who died suddenly and were diagnosed with a canalopathy was significantly younger than the age of those diagnosed with a cardiomyopathy. In order to explore trends in prevented sudden death, an additional analysis was performed with inclusion of ICD therapies occurred in patients with inherited cardiac disease in the region during the study period. Of the 370 cases of sudden death equivalent, there were 113 prevented deaths. No evidence of an increase in the proportion of prevented sudden death cases was observed during the study period. Of the 53 cases of resuscitated cardiac arrest, 28%, died due to the brain damage. 32 cases, 60%, recovered a good neurological situation. 4 cases had moderate impairment, and 2 went into a coma or vegetative state. Multivariate analysis of clinical predictors of severe neurological damage show that the only associated variable was the resuscitation duration. No association with the type of heart disease or sex was observed, although there was a lower percentage of patients who underwent therapeutic hypothermia in the group of severe neurological impairment. This difference was not significant. Conclusion and take-home message. Inherited cardiac disease are the main causes of sudden death in our region, with an annual rate of 1.9 per 100,000 inhabitants. A fifth part of non-ischemic cardiac arrests were resuscitated. Prevented sudden death remained stable despite implementation of preventive strategies. Female sex and canalopathy are more prevalent among resuscitated cardiac arrests. 2/3 of resuscitated cardiac arrests had a good neurological recovery. The only predictor of neurological damage was resuscitation duration time. We also want to do some questions to discuss later with the audience. What is the true incidence of sudden death in inherited cardiac diseases? Which is the percentage of cases of sudden death without a full autopsy is too high? What is the yield of adding genetic tests and family study? Are we using all available tools for prevent sudden death? Do we have a correct network of automatic external defibrillators? Do people know how to use it? Which are the causes of failing sudden death prevention strategies? Thank you very much.